Thanks for joining me today. We'll start by having each of you introduce yourselves and just explain in a general sense what you bring to this conversation that we're having today. So Katie, I guess we can start with you.
So I'm Katie Buckman, second year student at PNWU.
Second time guest.
Yeah. And I'm here today to talk about my own experiences with chronic pain from migraines. I still have migraines from time to time, but luckily they're not anywhere as bad as they were prior to last November when I started a new once monthly biologic injection that just came on the market last April. And it has just changed my life. But I still have quite a bit of experience with chronic pain and the use of opiates in it. And so I guess I'm just here to offer that perspective.
Perfect. And Matt?
My name is Matthew Brown. I'm new to Washington. I lived in Maine for most of my life, and I'm a person in long-term recovery from substance use disorder since August 5th, 2009. And early into my recovery, I got very passionate about trying to help adolescents struggle less than I did through school and better deal with the pressures of growing up and how to navigate all those challenges and stressors. So I started talking to youth, sharing my story, my life lessons, talking to parents. I started branching out and trying to equip clinicians and health profession students on skills they could learn to better address the population I care about so much. I just threw myself into this work and got involved at the policy level, serving on some statewide task forces and crafting opioid and substance use policies that would be helpful. And along the way, I started working at the University of New England College of Osteopathic Medicine and met our provost here at PNWU now, who inspired me to start collaborating with the chronic pain community and thinking that on a fundamental level, society has pitted them close together. For some, opioids are very life-saving, and for others, they can be life-taking. And so the overdose being the center of the conversation over the past few years has really done a lot of, I think, bad things for both communities. And so he encouraged me to start connecting with some of the people with chronic pain that he'd collaborated with, who were students of his, who were community members. And I just started having these remarkable conversations and realizing that there's so much similarity between these two groups. And if we can move more towards individualized care and comprehensive care, maybe we can develop some policies that will help both groups together and stop this internal clash that's been happening.
So it seems like an interesting pairing with having each of you on, but the idea of having each of you on, and we discussed this before we started recording, was you come from a side where you had a real benefit and you come from a side where you had a harm. And that is a public conversation that it doesn't seem to be carrying out very well. There's real nuance to, as we discussed, prescribing and treating pain. And if you come up with some sort of a blanket rule, it seems to do harm to everybody. And by sharing your experiences, I'm hoping that we can see that it is nuanced. It's a complex issue. And if we can look at it in terms of this individual might need it and this individual might not, and it's not some sort of an evil and it's not a save-all, then we can have a reasonable discussion and reach some sort of a conclusion that's beneficial to both groups. So Matt, we'll start with you and just sort of your background. So you're approaching 10 years of sobriety now, which is remarkable in and of itself. I know so many people who have struggled themselves, and I think that everybody in the room and basically everybody listening has had the experience of, whether it's them or somebody that they're close with, has struggled with these. And again, before we started the conversation, we said the word opiate, and just the entire idea of it has a really negative connotation because of that. And it's very rare that you hear somebody say, it really benefited me, I really needed it, and it really helped and saved my life. More often you hear, it was terrible, it took my life and it put it in a downward spiral, and many people don't escape from that spiral. Matt, can you talk about the experience that you had that led you to be such an advocate for this?
For which side? The substance use disorder side, the pain side, or both? Kind
of both. And again, it being such a complex issue, I think that both end up colliding somewhere in the middle. And whether you are somebody who ends up in a downward spiral, as we said, or you're somebody whose life is saved by these prescriptions, there's a conversation to be had on each side, and when they meet in the middle, that's where we can start to create change, I think.
A lot of the people with underlying substance use disorders either have unaddressed trauma or they have untreated mental health problems. There's actually a lot of overlap, and I find that when people start to get treatment, often the trauma and the mental health isn't addressed very well. While some from the substance use disorder side still talk about the harms of opioids, when I think about my own story and some of the stories of my friends who misused substances, we did it to try to self-medicate what we didn't understand about ourselves. And so opioids and other drugs that I used were one of the greatest solutions I ever knew until they stopped working and they started causing me a lot more problems. But to simply say that opioids were bad and wrong and all that stuff isn't the prevention message that I like to give to youth. I'm much more interested in equipping them with resiliency and the desire to keep growing and the ability to deal with the pressures of academics and from parents and from society. And if we can get them to that point where they don't feel compelled to turn to something that could harm them, that might help them in the beginning like it did with me as a solution, but ultimately harm them, and instead them choose to seek help, talk about their problems, turn to their peers, just be vulnerable, that's going to be much more powerful in the long run. It's going to be better for them. One of the problems that I've always seen with helping people get well is we say, okay, so on one hand, people using substances, it's one of the greatest solutions they ever know. And then society says drugs are bad, you have to stop them, but doesn't offer a better solution in its place. Mm-hmm. And so that to me is really problematic. How are we going to remove one solution without offering something better in its place? From my early recovery, I always saw this issue is very complex and very nuanced, and I really like living in that nuance. I found it very fascinating. And talking with my friends and other people in recovery all across the country, I realized just how diverse experiences people had.
And looking at some of the statistics across the United States, the places that have the highest opioid addiction are also the places that have the highest prescriptions for antidepressants. And they're the places that have a lot of unemployment, and they're places that have all of these underlying factors. And that's not a coincidence. It's people who need something. And when they find this something, it somehow fills that gap. Is that similar to your experience?
Yeah, I'd say for people who are prone to substance use disorders, ultimately they're trying to fix some aspect of their life. I think it's important to talk about and to highlight that there's a big difference between addiction and dependence. And that's a conversation that I've seen get very muddled. But there is a big difference. I mean, you take a substance, even if it's not a euphoric substance, your body becomes dependent on it.
Caffeine.
Exactly. Or even antidepressants that often don't have that euphoria. Your body becomes dependent on it, and you go through withdrawal if you don't have it or if you don't have the correct dose. But that doesn't mean that someone is going to become addicted to it, even if the substance is highly euphoric. There are other biopsychosocial, genetic components that we don't even fully understand why certain people are predisposed to it and why certain aren't. But only 8% of the population in the United States has a substance use disorder. And if we think about opioids in particular, I don't know, it's something like maybe 1 million or 2 million people who have an opioid use disorder out of that 20 million. On the other hand, there are 100 million patients with chronic pain in the U.S. So, a little under a third of the whole population. And there are, I don't know now how many are on opioids due to the policy changes at the federal and state levels. But at one point, there were probably tens of millions of patients who were reasonably stable on opioids, weren't addicted, but were taking them in order to improve their quality of life and to bring their pain down to a much more manageable level. Probably never completely eliminated it, but for them it was probably really important in order to get out of bed and participate in life and have that quality of life closer to what they need.
Well, and kind of going off what you had said about, they get on this substance and then it's looked at as a societal problem. So then there is no plan to get off of the substance. And I was actually watching a TED Talk on the drug war, and he made this really fascinating point about, if you look at tobacco is a highly addictive substance, and thanks to different things like education, and then nicotine patches, and we have medicine, we treat it like a disease. There's a lot of people who can quit smoking. However, somehow we think that nicotine and opiates are different, any kind of substance really. And so, we just don't have it. We don't have an exit plan for patients right now, and we look at it as a personal problem, and we treat it criminally and not as a health problem.
Mm-hmm. You are, what Matt was discussing, you're a perfect example. Somebody who had chronic pain, who had a benefit. Can you discuss, again, in our pre-conversation, you brought up a fascinating point about a doctor who hadn't met you before, who came into the room and had this preconception. Can you talk about that a bit? Because that was really shocking to me, but really, I guess it shouldn't be shocking with the conversation.
Yeah. So I guess I just want to share what it's like when I have a migraine, especially a really bad one. It feels, for me, it was like a headache all around, but mostly a stabbing pain. For me, it was always in my right temporal area, and it is just excruciating pain. It would radiate down into my teeth. Any kind of movement whatsoever made me sick to my stomach. I would often throw up because the pain was so bad. It was hard to get fluids down. You kind of felt hopeless as it was happening because you don't know when it's going to end. They're really unpredictable. And so sometimes I needed to go to the emergency room because I was dehydrated, and sometimes things like steroids, IV steroids, can help a lot. And so I went to the ER one time, and this doctor came in. He didn't even come in and introduce himself. He just kind of was standing at the door, and he just says to me, well, opiates are contraindicated in migraine care, so you're not going to be getting any of those today. And I was just so taken aback and angry by that, because he didn't ask me at all how I was doing, or he didn't do an assessment on me. He didn't even, I'm guessing he didn't look at my previous ER visits, because you would see that I didn't receive opiates in the ER, nor did I ever request them. It was fluids and ketorolac, which is a really strong NSAID, some nausea medication, and steroids, and that typically was enough to help me along. And so but I mean, on the flip side, I can understand where that burnout would come from, because a migraine headache is an invisible illness, and it is really easy for people who are drug seeking to go in and say that they have a super bad headache. But you need to, I think that a lot of times there are ways that you can tell who actually has a migraine and who's maybe just drug seeking in their behavior. And the fact that he didn't even give me a chance to talk to me and hear what my situation was just really unsettling.
Yeah, when you're going in so vulnerable, I mean, if you're in a doctor's office, you're vulnerable as it is, because you're putting yourself out there and trusting somebody else to care for you. In a situation where somebody comes in and passes judgment that's that extreme, especially, and kind of makes the assumption that you are here simply because you want some sort of a drug.
Right.
And
it makes you not want to seek care at all. I am on a Facebook migraine support group, and to see posts from patients that have had similar experiences, they are in a same situation as me, where they're just miserable, and they really do need that type of care. And in some cities, there are infusion centers, so they don't have to go to the ER, but there's nothing like that here in Yakima. And so my only choice is the ER, and that's the case for a lot of patients. And a lot of them are hesitant or just flat out refuse to seek care, so then they suffer at home because they don't want to face this stigma and judgment.
Now, back to the basis of our conversation and just the people that we have collected here at the table, I think that it would be inarguable to say that somebody in a situation like yours could very well take the anger that you felt towards that doctor and redirect it at people who have substance use disorders and say that you are at fault for me not being able to get the care that I need. And I think that that's why this conversation is so important, because when you put two sides on opposite ends and make them compete with each other or combat each other, you're never going to have a good result. And that seems to be the case here, is these people who really need help look at the people who abuse these substances and say, it's your fault that I can't get help. And the people who have a substance use disorder look at the people who really do need help and say, I need help too. There's, there's something here that is missing as well. And I'm not trying to be an enemy of yours. I'm trying to help myself in any way that I can. Yeah. And both sides end up at a loss.
Right. Well, and both sides are sick and both sides need help, like you said. And so I think that's one of the things. I'm really glad we're having this discussion today so that we can hopefully get the dialogue going of not trying to just legislate these black and white rules for prescribing narcotics, but instead looking at the big picture socially and personally and what needs to happen there to actually have a good solution to this problem. Because right now I feel that we have this knee-jerk reaction of, the answer is to just not have them available at all. But I mean, people are going to get their hands on substances no matter what. I mean, that's how we now have this heroin epidemic. A lot of it started from prescription pain meds. Then all of a sudden they were withdrawn. And for some reason, I guess some physicians don't understand the actual biological dependence on opiates and how sick someone can get in withdrawing. So going just cold turkey is not an option. And not to mention, I'm guessing there was no psychological support given as well. And so of course people are going to turn to, wherever they can find heroin or someone else selling pills or, so.
In your time working in the field, Matt, and just speaking with people, have you seen this conflict existing, and have you come to any sort of conclusions on it in the work that you've done?
Yeah, there's been a lot of clash. I've had a lot of conversations with people on Twitter, on Facebook, at conferences, both from the substance use side and the pain side, and there is very little collaboration. I'm hoping that has been changing for the better. I think we're making some progress, but both sides need to listen to each other and hear each other. And we're going to have very different ideas. And I mean, it's been said that with substance use disorder, there's so much stigma that it's hard to really educate people out of that prejudice and bias. And it's only when you meet people in recovery or struggling with substances, and I'd say same thing on the pain side of things, when you meet pain patients or people struggling with pain or substance use, the best way to change your ideas about those conditions is to meet someone and have genuine conversations with people who matter to you. And so we have to listen to each other's stories. We have to put aside some of our prejudices. And I think when we continue to have these heartfelt conversations, we'll continue to realize that there's so much more in common than their differences.
Mm-hmm. In your experiences, the stigma is so big, and I think that's another one of the gigantic problems, is you can't overcome that. You can't start to have a conversation with somebody when they look at you as some sort of a bad guy in the conversation in the first place. Have you had that experience, and how has that shaped the conversations that you've had?
The World Health Organization considers substance use disorder the most stigmatized condition in the world. And there's so much stigma at the society level, the community level, and even on the individual level. People feel that stigma. They feel so isolated. I mean, just the things that lead up to self-medicating with substances, we feel tremendously isolated and alone, and like nothing is going right in our life. So then when we have those negative internal thoughts with the societal stigma, it's just a million times worse. People need, research has shown that the best things to help facilitate recovery from substance use is a stable home, having good health, and health needs to be much more comprehensive than it has been. We can't just focus on the physical health, I mean, my insurance has almost never reimbursed mental health care, but it'll pay for 2 dental visits a year and 1 annual physical. Mental health is just as important, but it's that silent thing that no one talks about. And there's 9 dimensions of wellness: environmental, spiritual, intellectual, physical, environmental, financial, occupational, and social. And one of the most important things for people is having a sense of purpose. And often that gets left out of the conversation because people, with their backgrounds, whether they're, a lot of substance use disorder intersects with the criminal justice system so much. It did with my life for sure. I was arrested in 2008, almost arrested in 2009. I was facing some jail time for my substance use and the activities I got into. And I thought that that was going to prevent me from ever going into medicine, which was one of my lifelong dreams. And when I started, I actually decided not to apply to medical school for about 4 or 5 years, and that was part of the reason. And then I got to the point where I was doing a lot of education and felt very empowered in my own recovery, that I realized the world needs more physicians who understand this and who want to make a difference for vulnerable groups like pain patients and patients with substance use disorder, that I decided to turn my passion back towards pursuing medicine. And PNWU took a chance on me, and they interviewed me and accepted me, and I'll be coming here as a first year in the fall. And they're helping me reach my dream, my ultimate dream of being a physician. And I'm very fortunate. And unfortunately, a lot of my friends and others I've heard about don't ever get the opportunity to pursue their dreams of whatever it is, whether it's going into acting or going into law school or whatever else, or just feeling like they're a member of their community again. It's they feel like they are still ostracized, even sometimes years in recovery. So having a supportive community and friendships and connections that foster love and hope are also really, really important. And I don't think we can get through this without coming together as a community and recognizing our own humanity and reaching out to each other and saying we're all in this together.
It almost seems obvious when somebody who has susceptibility to a substance use disorder is susceptible in many cases because they have these missing pieces in their life where they feel ostracized. They don't feel like they're a part of the community. They don't have a purpose or a passion. And then you take them when they're struggling at their lowest often and criminalize that and push them even further outside of society, expecting that they're going to get better and heal themselves and be beneficial to a community it doesn't make sense.
No.
Yeah, the fact that it's 2019 and we still are putting so much money towards, the criminal pursuit of people as opposed to trying to get them better and heal them is just, it's mind-blowing and so disappointing, to be honest. And this is why I think Matt's going to make an excellent osteopathic doctor, because he has this 8 dimensions of wellness and what he mentioned, because that's what the osteopathic approach is about not looking at them just the physical symptoms and complaints and whatnot, but looking at them as a whole, which is obviously, as we've discussed, a very important part of opiate use and misuse. And one of the experiences I had before coming to PNWU, I figured out that I was really interested in becoming a rural physician. And my husband is from Pendleton, Oregon. And so I thought that would be the perfect opportunity to shadow some docs over there and see, what it's like to work in a rural community. And so one of the family docs I was following, he saw a bunch of patients that day, but most of them were chronic pain complaints. And he discussed with them the importance of options like physical therapy and trying to wean off the opiates. And a lot of them were very resistant to his suggestions of physical therapy or any other therapy besides opiates. And so afterwards, when I was talking with him, I asked where he thought this reluctance stemmed from, and I was in a much more naive place. But he responded, well, what gets you out of bed in the morning? And I was kind of taken aback, and I'm like, I don't know, my dog's pretty hungry. I gotta get up and feed him. And he's like, no. What's your goal in life? And I was like, to become a doctor. And he's like, exactly. And then he was talking about how, Pendleton, there's not much industry there. There's a prison. And so a lot of people work for the prison. But other than that, there's not a lot of opportunities for growth and personal development. And then not only that, but a lot of the patients that we had seen that day had, unstable home environments as well. And so it definitely kind of opened my eyes to all of the factors that go into substance abuse and misuse.
There's a real complexity to those factors. And I think that one thing that ends up being kind of a problem in this entire system is the idea that every time I have a healthcare conversation, many people say that even physician burnout is caused by the fact that they don't get enough time with their patients, that it's 7 minutes and then they're out the door and somebody else is coming in that same revolving door, and you have 7 minutes with them and you figure out what their problem is, solve it as best you can, move them out. With something as complex as missing link in life that might lead somebody to something else down the line, you're not going to find that out in a quick amount of time, and you're not going to develop the relationship with the patient that you need to. But to say that a physician isn't providing a huge benefit by having an experience that they can relate to the patient's experience it's ridiculous. If you had a doctor and you were going for heart surgery and your doctor said, I had the same heart surgery that you did and this is how I did, you'd probably feel a lot better going under. But the expectation that you wouldn't feel the same way if you had some sort of a substance use disorder and your doctor said, I also had a substance use disorder and now I'm in this position, I'm a doctor, obviously that's impressive enough, but you can relate to that person, and it boils back down to a human level. And taking those people who've had these experiences in the past and removing them from a system where they could potentially provide a huge benefit, again, seems like working backwards.
Mm-hmm. Absolutely. Yeah, I mean, I think that, so last year, before I got this, to me, life-saving drug, I was having migraines so frequently that I was missing a ton of school, and it put me behind in my coursework, obviously. And then that just added more stress, which, was probably contributing to future migraines. And it was just a really awful time. And it was about this time last year, actually, coming to the end of first year, that I lost it and was crying in my doctor's office and said that there's just no way, I have to drop out. This is just, obviously, I'm not meant to do this. And, at that point, I was just feeling so hopeless about any chance of ever living a life other than what I was living. And the most meaningful thing was when he closed his laptop and grabbed my hand and said, we need to have a heart-to-heart. And he told me that medicine needs more doctors like me, and that I need to keep going, and that he'll get me through this. And that when in the future, when patients come to you and say, oh, doc, I'm experiencing just the worst pain ever, you can't even imagine, like, I'll be able to say to them, I can imagine, I have been in pain like that. And so, yeah, I think there's definitely a huge benefit as to what Matt and I have experienced. And I'm glad that we are both open in sharing our experiences to hopefully open the eyes of our classmates and others, so that we can start to have more of an understanding.
And something Katie's physician did is so powerful in highlighting that a relationship between clinicians and patients is one of the best indicators for success for a patient. It's not the severity of the disease. It's not the other life circumstances. It really goes back to, if you're a clinician, even if you don't fully understand what the patient's going through, and you show up for them and you're right there 100% of the way and 100% of the time, that you're going to make an incredible impact in their life. And you may not be able to fix a lot of the problems that are going on outside of the medical side, or even in the medical realm, you might not be able to help your patient through as best as you'd like to. But making sure you're there for them, working with them together towards shared goals, is going to make an incredible difference. And that's why I don't want to say that you have to be in recovery, or you have to have gone through chronic pain or substance use disorder in order to make an impact for patients with these conditions. If you bring out your humanity and you show up for them, no matter your personal background as a physician, you're going to have a remarkable impact in your patient's life.
Yeah, absolutely. And to that point, so I do this program called Adopt a Grandparent. And so every month I go and I have dinner with my adopted grandparent, Bob. And Bob was over in Seattle with a very serious illness. And he told me all about the different doctors that he saw. And he would tell me, oh, well, this guy, he was terrible. But this other doctor, he was fantastic. And I was like, what made that one doc terrible and the other doc fantastic? And he thought about it, and then he said, well, I guess neither of them were more knowledgeable than the other. It was the way that they could connect with me and take care of me personally. Like the one doc that he loved could tell that Bob was in an immense amount of pain and wasn't really able to focus or have a conversation about his care plan. And he said, do you want me to call your brother? And Bob's like, yes, please. And that meant the world to him, that he thought of, like, oh, I can see that you're not handling this well. Let me think of another solution of how we're going to talk about your care. And yeah, there's a train.
There's always a train. So in the patient relationships that you're talking about, it's a doctor being able to understand the person that they're caring for. If you can't understand the person that you're caring for, you can't best care for them. And I think that what happens, and what's certainly happening now, is there's an undeniable epidemic going on with opioids. And there are so many people dying, and there are so many people whose lives are completely derailed by this. And when you see those things happening, it forces you to say, we have to put a policy in place. We have to come up with a rule to stop this from happening. But in such a complex conversation and in so much layers to a patient's life, when you put a policy in place and say, this is the rule and everybody's going to fall under it, you do more harm than good, it seems, even though you're, of course, working towards doing good. What sort of, and again, coming back to the work that you've seen, I'm sure you've seen over this course of time where it's, since your own personal struggles and the 10 years since has really been the hotbed of this problem just escalating rapidly. And in that time, I imagine there's been so many policy changes, and clearly they're not working. What have some been that have been frustrating to you, or some that you've seen that may have had some sort of a potential to them?
Two things stick out to mind immediately. One is it's important to offer better substance use disorder treatment and make it more widely available. But at the same time, the talk always seems to be about treatment. It's never about treatment that facilitates recovery. It's never about wellness. It's never about what looks like post-treatment. And so having the best treatment in the world without community supports and without other important recovery supports outside of that is going to make it, I think, very hard for people to sustain that quality of life and life-sustaining recovery that is going to be so important for them, for their families, for their community, and for the nation. So we need to get our tunnel vision out of the way and talk about the whole continuum and make sure that there are good barriers from treatment centers and from jails and from other entry points into the recovery community, including the use of recovery coaches to help people navigate some of the barriers and needs that they're going to have after they're medically stabilized. So it's good to talk about treatment, but we're still not being comprehensive, and we're not elevating the many paths to recovery the way that we should. So I think recovery always gets the short end of the stick, and it's important that we elevate that wellness conversation a whole lot more. And the second one, I showed up for Maine's opioid prescribing guidelines and testified, and I testified against it because I worried that making a blanket policy on the morphine milligram equivalent of opioids across the board was going to be very problematic. It's eliminating all the individuality in a patient's life. It's getting rid of genetic differences, that sometimes people are over metabolizers or under metabolizers of codeine just based on their the alleles in their liver enzymes. So it really gets rid of all the science behind all that stuff, and it moves away from individualized care when we should be moving much closer, more towards individualized care. So I had a feeling that this was going to cause a lot of pain patients who needed opioids to be forced off their medication, and that it was going to cause a lot of physicians to be afraid to prescribe, and that there was going to be punitive action from the DEA and the licensing boards. And we've seen that, and we've seen a lot of pain patients whose chronic pain just came back and spiraled, who turned to the streets and found illicit substances, or even worse, ended up taking their own lives. And people predicted that this was going to happen, but still it took a few years for the federal government and for people to really talk, to elevate that there were problems with this. And I hope that we're going to see a revising of the guidelines, especially that it shouldn't be weaponized the way it has. That there were exemptions put into place, that if you had like, I forget what the exemptions were, maybe a palliative care exemption or hospice care exemption or something like that. And a lot of people talked about, let's still make opioids available for cancer patients, but cancer patients are now being denied opioids at end of life. And so there's a lot of, it was totally weaponized, and a lot of patients were forced off their meds. And the CDC guidelines didn't even talk about how to appropriately taper patients. So there were these abrupt cessation of medications, even physicians saying, I can no longer treat you anymore. You have to find a new clinician. And I'm being overly dramatic. I think that we're seeing this. It doesn't mean that every physician everywhere is doing that. We do have a lot of really good physicians who are stepping up and saying, I still care about you. I'm still going to work with you. It's going to be hard for both of us, but you matter to me. And let's make sure that we can do whatever we can within the terrible confines we have right now to help you improve your quality of life. But I mean, being interested in the pain and substance use sides and going into medicine, I worry about what the policies, if they're going to allow me to practice medicine the way that my clinical judgment would allow me to. And I'm fearful about that future, but because my patients are going to be the most important, and I'm not entirely sure in this climate how I can be as good of an advocate for them as I'd like to be.
Mm-hmm.
I think I have a lot of thoughts right now, but
Yeah.
I think what it comes down to is that people, it's multifactorial for sure, but I think that people don't see that. They don't see all the factors that are involved in this. To them, it's an easy solution. If we limit the amount that physicians can prescribe, then we won't have a problem anymore. That's clearly not what has happened, and it's not fixing anything. And like we've discussed, it's hurting patients. And so we actually just had the Washington Osteopathic Medical Board come and speak to us. And one of the things we talked about was narcotic prescribing. And they said that it was a really challenging task force to be on because there is no box that you can put everybody in. It's so individualized. However, we live in a society where we feel like we just need to write a law for everything, and that'll somehow fix the problem. But instead, physicians are now afraid to prescribe narcotics, like Matt said, because of any repercussions that'll come back, or they don't clearly understand what the guidelines are, the language of the law and whatnot. And some physicians are just flat out refusing to deal with it and saying, I'm not going to prescribe narcotics anymore, which, I mean, I'm only a second year medical student, but I agree. He said that it's irresponsible of the physician and it's a disservice to their patients. And I agree with that. And just because it's easier to say no and not prescribe them at all is just, it's harming patients.
There's definitely a lack of pain medicine and addiction medicine education in medical schools and in residencies. Tufts School of Medicine and Stanford School of Medicine, they're both leaders in that sense on the pain medicine side, and clinicians and physicians, researchers there have talked about the problem with not having the right education there, because then we have physicians who are in primary care settings responsible for addressing substance use disorder and chronic pain more than any other specialties, with limited knowledge on what to do. And one of the most important things I'd like society to do now is take seriously the experiences of the 100 million chronic pain patients, the 23.5 million people in long-term recovery from substance use disorder, the 8% of people currently struggling with substance use disorder. Learn from their experience what their barriers are, what their needs are, put it into comprehensive documents, spread to the medical community, so we can see just how diverse individuals are and what the treatment modalities were that were best for them. It's not all going to be substances. It's not all going to be opioids. Some are going to say occupational therapy was best for me. Some are going to say physical therapy. Some are going to say, and actually I've talked with veterans who've dealt with serious trauma in their past, not just from the war, but from deaths in the family and all sorts of other horrible things. And they've been vulnerable and shared that with me and said the best thing that helped my chronic pain in my life was to be empowered, especially to be empowered by their peers and to join support groups and to be able to speak about the issues that mattered to them from the public stage, speaking with legislators and speaking with medical students and with clinicians and saying, I need you to hear certain things about me that you're not going to get from a formal educational setting. So we really need to better listen to the wealth of expertise that all these patients have.
Mm-hmm.
I remembered what I was going to say. So the other thing, I completely agree with Matt about being fearful of legislation and insurance companies. I mean, it's already a huge problem, and I don't see a solution in sight. I think it's just going to get worse. I mean, so my husband broke his leg a couple of weeks ago, and he obviously is in considerable pain and was prescribed Vicodin for his pain. And the doc wrote for 35 pills, I believe. And when we went and picked it up, well, I picked it up because he can barely walk, picked it up from the pharmacy, there were 14. And we didn't notice until we got home. And then he said something about, oh, I thought I saw the number 35 when I dropped it off. Turns out that his insurance company dictates how many pills are dispensed at a time. And to me, the fact that an insurance company can have any say whatsoever on the dispense of medication is just, I mean, asinine. I mean, it's like, I just wish that the legislators and the insurance companies could accept the fact that we are going through this rigorous education for 8+ years of our lives, and that we know what we're doing, and to trust what we think is the best care plan for the patient that we know and that they do not.
That seems fair. I think one of the problems with your solution and your ideas for starting to address this are brilliant, but they're challenging and they're not simple. And it's so much easier to come out with a blanket statement saying, we're only going to give you 14 pills. That's going to solve our problem. And now it's a rule, and now everybody's going to follow it, and this is going to work, rather than saying every single person that we have an experience with as a patient is a complex individual with a variety of life experiences that have led them to us. And what we do to treat them is going to differ from what we did to treat the last person.
Mm-hmm. Well, and I mean, like, what if it's hard for him to get around? And so what if he didn't have me or anyone that could go and get his prescription for him? And I'm sure that there are lots of patients out there that have trouble with access to cars or transportation in general. And so if they were in the same predicament and had to now make a weekly trip to the pharmacy, I don't know, that's just another inhibitor of care.
Yeah, there's a definition of recovery that I like talking about a lot, a process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential. And that was created about mental health and substance use disorders. It also applies to people with chronic pain. It also applies to any patient with any condition. I think that it's to best help our patients, let's have a conversation now about what are your immediate barriers and needs, what's going to help you at this present moment improve that quality of life even slightly, and let's continue to regularly monitor what's happening and continue to have a dialogue back and forth about, is this working or is it not working, and what should we do to continue to improve that quality of life and help you reach that full potential.
One thing that I found so interesting in our pre-conversation was the fact that, again, substances such as opiates are demonized in culture almost completely. When you hear the word, you instantly think something bad. You brought up the fact that that's not the case. They're not a monster in a pill, and that there are real benefits to them on both sides. And sometimes the benefits that a certain group receives, of course, are not really benefiting their lives. But it's an important way to discuss it with people who are struggling, whether it's with pain or with some sort of an addiction, to say that we recognize that this is doing something for you. Can you talk about that a bit more? Because again, I feel like that's a huge piece of this conversation that is so often lost.
Yeah, substances and opioids, they're doing something for you that life clearly isn't. I mean, they did when I was dealing with the pressures that I had, my inability to connect with my peers, my shyness, my quietness, the academic pressure, the athletic pressure, all this stuff. I was trying to build a life for myself, but I didn't know how to deal with it. I didn't know how to deal with the depression or the anxiety or some of the other minor traumas that I was dealing with at the time that I couldn't even explain. So when I found these substances, they totally opened up my life, allowed me to calm my racing thoughts, to calm my brain, to feel like I was in control of something, that if things weren't going the way I wanted to, I had this escape, I had this solution. And so they before they made my life worse, they made my life a whole lot better. And of course, I wanted to use it for the rest of my life. It was the best solution I ever knew. And so we need to think that they are doing something for people that life isn't. And if we can figure out what life isn't doing for them, then we can better figure out how to help them avoid that problematic use and down the path that's going to ultimately help them, and that's going to ultimately help them work through whatever it is they can't fully explain at the time. And it certainly isn't going to be an easy process. I mean, my depression and social anxiety has kind of come and gone. Almost 10 years in recovery, I still deal with some of that. When I meet new people, I have some social anxiety and aren't always sure how to connect with people until I get closer to them, until I take risks and share a little bit more about myself and develop that connection. So there's lots of simple things that have to happen at the community level. We can't just expect youth, especially with their not fully developed brain, to be able to navigate all these pressures without knowing the resources, without understanding even how they're wired. So we have to be present for each other in communities and think about how to direct people towards achieving that quality of life they need.
When you find purpose that you've found too, I think that is one of the major steps in recovery. And it seems that so often people who have disorders with substances can overcome the chemical side of it, and they can work their way out of that. But when they get to the end of the line, as you said, there's not some sort of a step afterwards that gives them a reason to not go back to the thing that was replacing that thing that's still missing. And that's such a challenge. What sort of advice, and the people that you've spoken to who have faced these sort of struggles and may overcome the chemical boundaries that encompass their addiction, what sort of advice do you give them for making sure that their recovery is going to be long-term and that they're not going to fall back into these trappings of this replaces something that nothing else can?
It's easy to convince yourself that problems are more minuscule than they are. And I'm someone who doesn't like to talk about my problems, and sometimes they'll spiral a little bit inside my own head before I feel enough pain to want to address it. So making sure to address things early, even if you don't understand it, there's always people. You can always find people who you can trust, who will sit with you in your pain and help you process what you're going through. So making sure to talk about our problems. We don't need to have this attitude of everyone needs to be macho in society, especially men. So that's one thing.
I mean, I don't really have like, I mean, there is no simple solution, just as we've discussed many times, but I think helping, and this is where like interprofessional medicine comes into play, because I think getting, obviously therapists involved, social workers, family, whatever, to help that patient find their sense of purpose in life at the end of the road. I was just listening. I listen to a lot of TED Talks, but I was just listening to a TED Talk that was talking about rates of isolation in recovery, and how that's a huge factor in relapse, is when people are isolated and don't have the social support that they need. So yeah, I think that there's not anything in particular I could say or recommend, but that as a physician, you would need to be cognizant of the complexity of the road to recovery, and that it's not just we got you, withdrawn off the medications medically, and now you're good to go, you're cured. But it's like, that's not the case. And there definitely needs to be more work to figure out what the plan is in the long term.
Mm-hmm. There's this statistic. One thing that I wanted to make sure that we avoided in the conversation, coming from a medical school, I think that it's very easy to look at this from an outside perspective and say that you're trying to protect the group that so many blame for this, which are physicians who've overprescribed. And I don't think that it's deniable that there has been severe overprescription. Okay. There's this stat that I read almost anytime you look into anything, that there's enough prescription pain medication, opiate prescriptions in the country that every man, woman, and child could have their own bottle of pills, which is outrageous to think about. But when you're trying to come up with some sort of a policy, again, it doesn't fix the problem of the individual patient that you're looking at. One policy that we were talking about again in our pre-conversation was this idea that you could prescribe people pills for a certain amount of days. Could you talk a bit about that and how that doesn't really work? Yeah.
So last year when we went to DO Day on the Hill, there was a piece of legislature about, and I forget the numbers, but it was like you could prescribe X amount of pills for 3 days of pain for someone who had not been on opiates before. But that might not be appropriate for the patient individually. And so one of the physicians that we were talking to with the legislators was saying that physicians can easily manipulate that and say, okay, well, I'm going to write a prescription for X amount of pills and just, change the timing of it from every 6 hours to every 4 hours or whatnot. So that was just kind of like a broken solution. I think that laws have their place, but I just think in medicine and in this situation in particular that I just say it over and over again because it's true. There just is no easy solution. And are doctors to blame for this opiate epidemic? Yeah, sure, of course. We wrote I didn't do it. I'm just kidding. They wrote the prescriptions, and that's how people got access to it. But I also think that there's a huge problem in our society and socially that drives, as we've been talking about, that drives people to addiction. We are notorious for never relaxing. That it's like you're just expected to work, and there's no time for yourself. And if you look at other countries and the amount of vacation time that they get, I don't know. It's that American thing. And so that definitely contributes. And I think that there's just so much that contributed to the problem. Physicians are to blame, but I guess to be fair, the information that they received at the time regarding the addictive properties of the medicine was false from the pharmaceutical companies. And so I don't think they were intentionally doing it, obviously.
Mm-hmm. Yeah, I'm always careful not to place blame on any one group. And so I'd say physicians played a role, as did many other groups. Insurance played a role in helping this spiral by choosing to only approve opioids and not approving other forms of chronic pain therapy, occupational therapy, physical therapy, you name it, the whole gamut. There's this thing called step therapy, which has become on a lot of has been discussed as a bill in many legislatures across the country. Step therapy, basically saying you have to fail on many forms of therapy before they will approve one that ultimately medical providers think is going to be the best for a patient anyway. So you have to do A through F and show it's been not successful before you can be given G, which G is going to help the patient. So why do you have to go through all those expensive, painful steps before you can get to the therapy that everyone wanted to give the patient anyway? So insurance has to change the way that they think about this stuff. I'd like them to not be so money driven. I'd like them to be more outcome driven and patient driven.
Same.
But yeah, certainly more education about the comprehensive nature, problem and solution for pain and substance use is something that I hope is addressed more in medical schools, including the patient perspective. Administrators and licensing boards, administrators of hospitals and then licensing boards, I think should have more supportive roles in supporting physicians and patients instead of creating environments where there's a lot of fear in patients and in physicians. So there's just so many different aspects. That's why I always say pain and substance use are community problems that require community solutions from all sectors. We all played a part and we can all have a solution.
Mm-hmm.
Yeah, definitely. And I think that, and that's one of the things we discussed in our pre-conversation is, the real solution is really to have more time with patients, to develop these just critical relationships. And that's something that, again, we're in this style of medicine that's about money. And so it's, if anything, patient times are just going to get even shorter. And there's just no way that you can address everything that needs to be addressed with some of these patients. And, insurance companies, especially, because a lot of time is by physicians. I think, I can't remember the numbers exactly, but there's just so much time that physicians spend doing paperwork and arguing with insurance companies about what's best for the patient. And then that cuts into patient time and revenue as well. And then plus everything's about documentation so that the insurance company's pleased with what you had done, what you had properly documented. And I'm not saying that like documentation needs to go away, because obviously that's critical both for the patient and for insurance companies and in a legal sense too. But where we're at is ridiculous. And there's a lot of data out there about like the amount of time physicians spend with like prior authorizations in insurance companies. And it's definitely not helping the problem in all areas of medicine, not just substance use.
Mm-hmm. You bring up before the societal standards that are set and how we're so driven by work and things like that. I've had a conversation on opioids with Dr. Bilski before, who you also brought up. And one interesting connection that we discussed in our conversation with sort of the cultural side to it was that this rise in addiction also coincides with a rise in people being more disconnected, communities sort of breaking, and even things like social media and the lack of human connection. And human connection seems so important and so crucial in finding some sort of a system for recovery and figuring out how you can get back to a normal life. Could you just share your thoughts on those sort of things, the things that are happening in society? Again, it's such a complex issue and it's so easy to try to boil it down to one rule, but it doesn't work. But when you look at the idea that you need something to fall back into, you need a support system, you need people who care about you, and you also need a purpose. And the idea that so much of that is being lost, it seems more and more as we go forward with a problem like this escalating and becoming an epidemic and losing more and more people every year. Where do you see that balance and those things playing off of each other?
The one thing I can say about, especially with the social media factor, is that social media is just, I like social media. It's a way for me to connect with my friends and family that are in different states. But you definitely see the highlights of people's lives. And I mean, no one goes on social media and says, "Ugh, I bombed an exam today," or I don't know, "I feel horrible." It's the highlights of people's lives. And so it's definitely a way for people to compare themselves to others, which is not good for those with depression or other social issues. And sometimes if you become more socially isolated, then you can look at other people who are, on vacation or have all the success at their job or whatever. And so, I mean, I would not doubt that is a factor into the increase in substance abuse.
Yeah, I'd say social media has been both really positive and really negative in my life and in society's life. I can't tell you how many friends and mentors and colleagues I've met across all issues and across the country, just from joining Twitter and connecting with people who shared similar interests to me and who had similar ideas. And so it's been really huge in feeling connected with the 23 million people in recovery across the country, and by expanding my own knowledge of these issues. But there's not a single time when I've gone on Facebook when I haven't scrolled past some form of vitriol as well. There's just so much hatred in this world. We hate what we don't understand. We hate what we think is different. And I still think humans are more similar than we are different, but no one is talking about that. There's a huge political clash. There's a huge issue clash. We're polarizing every issue I can think of. We're not having civil discourse. It's okay for people to agree or to disagree, but we're not even civilly disagreeing anymore. We're just arguing with each other. Even if we have the same ideas, it's like we can't hear what anyone else is saying anymore. So social media is creating this ripple effect of just spreading hatred and disconnecting us. And it's really terrible. And another thing I just thought of, when I was young in the 90s, I remember that a couple of times when I was on a family trip that we would stop with a car, pull over to the side of the road when a car was stopped. One time in particular when it was a blizzard and someone's hazards were on. And my parents pulled over and just wanted to find out if the other people in the car were okay, and if they had a mechanical problem or if they had a personal problem or whatever it was. And it was that sense of community that my parents were really wanting to make sure another community member was okay and got the help they needed. Driving past people now, my thought is never to pull over on the side of the road with their hazards on. I'm like, oh, I see that person has a cell phone. They'll figure it out on their own. So the wiring about being a part of the community has changed within my own mind, and I see society doing this as well. And I wish that we could get back to being there for each other much more.
Well, especially on social media. I mean, I sometimes read the comment section of articles, which I really shouldn't, because it kind of just, it's sad and infuriating, because so many people are so quick. It's like so depersonalized that so many people are quick to just say, I mean, especially there was just an article, I don't know, a couple months ago about chronic pain and the restrictions on opiate prescribing. And the comments in there were all like, oh, well, don't help those addicts. And, and then people, yeah, it all comes back to, it's just like they see the problem and they see an easy solution, and that's it. And they're just unwilling to open their minds to all the other factors that go into something. And that's with what we're discussing today. It's with all the other political issues in the world. I think that people are stubborn, and a lot of people are convinced in their beliefs and refuse to listen to others. And so, like what Matt was saying, I really hope that we can reach a point in a society to have civil discourse about different issues, because there's been lots of times, I think one of my strongest attributes as a person, and I haven't always been like this, but I have come to realize that I'm wrong, like a lot. And if I have an opinion on something, I'll share it with someone. And if they disagree with me, I always ask why. And there have been many times where I'm like, wow, I never thought about it like that. Like, that makes sense. And then my opinion changes because I have a more diverse view on the issue. And so that's just something that I wish more people could do, is be more open-minded, that there might be other opinions and yeah.
It's not us versus them.
Right, exactly. Yeah. And that, I don't know, that you might be wrong.
Yeah, and I think that comes back to the basis of this conversation. When you create one group as the bad side and you are the good side, and they see you as the bad side, then you're never going to find a common ground, and you're never going to work towards a solution that works for both sides. And when it comes to pain management, it's the same way. If somebody needs help and this substance can provide that help for them, and it's proven to provide that help, then there's no reason that it shouldn't be usable. And if somebody has a substance abuse problem and they need help in the same way, there's no reason that we should deny them the help because of some sort of a mistake that they've made in the past.
Right.
And by doing either, we're not going to build towards anything. So in just sitting down for a conversation like this, I'm really thankful that each of you are going into the medical field and that you're bringing this sort of experience and perspective to it, because it's so important to see that there really is a way out, and this isn't some sort of an endless problem. And by discussing it and looking at the nuances and the complexities of it, we could really have benefits to others' lives, and we can kind of see a way forward when a conversation like this many times seems so hopeless. And so I'm very happy to be joined to the table with each of you.
No, I think this is fantastic, and I hope that it's a conversation that more medical schools especially have across the country, because I mean, we're not taught these things in school. Of course, we know the pharmacology behind opiates, and we get at PNWU we have a very short 3-week course in behavioral medicine, but aside from that, it's not really discussed. We're kind of just focusing on the hard science of things, and it's something that you learn when you get into clinical practice. But even then, it depends on who your preceptor is and what type of an influence they have on you and the future way you practice medicine. And so I think that, yeah, I'm really grateful that we're having this conversation.
Yeah, it's really an honor to be here. I'm always excited to help be part of conversations like this, and hope that the conversations continue. And one last thing I'll say is that people in recovery are making the world a better place when they find that life-sustaining recovery. And I've met really extraordinary chronic pain advocates who are also making the world a better place, especially for their own peers, but in better educating the medical community about the complexity and what their diverse needs are. And so let's do as much as we can to make sure more people achieve the quality of life that they deserve.